With ligament, we do also treat ligament issues. So this is a good example of a woman who had failed multiple conservative tries. You can see here her talocalcaneal ligament there. You can see a break in that ligament. You can see what's left of the top row of the ligament there. And this is after injection of stem cells into that ligament. She had complete resolution of that lateral ankle pain. So as far as complications tracking are concerned, we've got somewhere between 300 and 400 patients, I don't know the exact number as of today, about 600 plus procedures. We actually have an active contacts database. That means that it's someone's job full-time to do nothing but contact these people. And I can tell you, it's not easy to do. It's very hard to track some of these folks down, to get them to respond. It's even harder to try to adjudicate their complaints. We do a complaints adjudication system where if anyone has any kind of complaint, like 2 months after the procedure I had a significant fever for 7 days, that's tracked down. It's adjudicated by a physician as to whether it's likely related, unlikely related, any change in their blood work, etc. So every little complaint that they make on these questionnaires has to be tracked down by a physician and classified in the database before anything can go forward. We have 3 tests of MRI surveillance on about 50 subjects. So a lot of MRIs, which you'll see here. We've had no significant complications to date. Here's a good example. This is the frequency of sites treated in a paper that we just got accepted for publication. It'll be published in March. This is a complications tracking paper, so you can see here about almost 250 contacts at 3 months, more than 150 at 6 months, about 100 at 12 months, and about 20 or 30 at 24 months. And this is the total number of MRIs that have been done in the other populations. You can see here 40, 80, 100 and something, about 150 MRIs that we have paid for on these 50 patients of the reimplant sites, and not just any MRI or an open MRI. This is the best MRI technology that money can buy currently that's on the market at the highest resolution. So Joe has allowed me to use this. Joe's a really good story of our classic patient. Joe is a neurosurgeon at University of Pittsburgh. He was an active triathlete. And about 5 years before we met him, he was told by his orthopedic surgeon that, Joe, you need a knee replacement. He wasn't competing at that point. But if I replace your knee, there is no way you're going back to running Ironmans. That's just not going to happen. So Joe sought out other options. We treated Joe. Joe is not perfect, but he's now back to running the Ironman. We actually treated him while he was training. Oops, sorry about that. Training for this particular race. So this is him finishing the Hawaii Ironman, which is a huge deal, after we treated him while he was training for that. And he's still, as you can see here, doing his thing. Again, not perfect, but able to do it now where he was not able to do it before. Thank you. Okay, any questions?
For your intra-articular injections, how are you guiding that? Arthroscopy, CT, fluoroscopy?
We use fluoroscopy. It's important to note that the animal research that's been done where they can take apart the joint, they can do histology, all seems to show that a general intra-articular injection mostly won't get you there. You have to be very specific about cell placement. So we use biplanar fluoroscopy to do that. You could use CT, although probably too much radiation exposure trade-off there. And you could certainly use arthroscopy, but it would probably have to be gas arthroscopy, not liquid.
And a quick follow-up, for soft tissue, are you using ultrasound testing?
We do use some ultrasound guidance, particularly in things like shoulder rotator cuff and other areas where it's more difficult to see. Our background is interventional pain, so we're very good with fluoro as well. So we tend to use mostly fluoro, but you could also use ultrasound guidance in most areas. You'd have a hard time in things like disc, for instance.
Do you do these as reimbursable procedures or just experiments?
Well, yeah, I don't make that distinction quite like that, but they're certainly not insurance reimbursable at this point. We did 2 years of not charging patients at all, completely through IRB under a research protocol. In late 2007, we switched to actually treating patients commercially. In addition, continuing our research patients is where all those MRIs came from. So we are now treating patients commercially, but it's not insurance reimbursable. And I suspect it's 5 or 10 years away from being insurance reimbursable. If we have insurance, I think that's, I don't know who said that, but that's a really good point. Yeah, well.
Chris, on your journey to get to where you're using the stem cells in the manner you're using them, were you using PRP at any point?
We use currently what I would call PRP 2.0. We use what are called activated platelet supernatants. So it requires incubation to use this kind of PRP, but we can create a custom designer PRP, upregulate things like TGF-beta, VEGF, FGF. So it's beyond the bedside unit approach. But I think PRP or platelet products are very important in doing work like this, at least for the tools we have right now.
The reason I ask you that question is I've been using PRP now for close to 2 years, and I'm looking at stem cells as this, is it better than PRP? And I have some case reports that we're writing up where PRP has filled in these OCD defects in just a few cases, but in patients that were very symptomatic athletes, reoccurring effusions and 2 treatments, and they're filled in like 75%. Not as much as yours, not as big as yours, but significant lesions that surgeons are sending to me to try PRP first before they take them and do Carticel transplantation and whatnot.
Yeah, and I think that's completely reasonable. I think what we've seen with PRP in using it is, and just so people know in the audience, he's talking about platelet-rich plasma, is that PRP is very good at kickstarting a healing response. So if you've got a stalled healing response, PRP, I think, is a great application. Where I think this would come into play, so what I would actually advocate is there's probably a lot of different tiers here. There's sort of PRP type applications, and if that doesn't work, then moving up to the next tier. PRP is clearly a lot cheaper and less resource intensive. So if it's something that is probably could have healed but never got there, I think PRP is a great way to go.
I actually have 2 questions.
Yes.
Is there any common characteristic of patients? Thank you, that's better. Any common characteristics of cells from the patients that grew the cells in culture better than the others?
Oh, yes, I know what you're saying. The answer is we believe so. We're looking at that data right now. We finally have enough clinical culture expansions, about 600, so that once we slice and dice the N into various groups, we have a big enough N left over to look at statistically. And I can tell you just that we believe that, for instance, activity level makes a big difference. In particular, perimenopausal females are really bad mesenchymal stem cell culture expanders, which would certainly fit with the model of osteoporosis that occurs. So we're seeing some of those things right now. Also, patients on prescription medications, which is a little frightening to consider. Statins in particular are very hard on mesenchymal stem cells. ACE inhibitor drugs are very hard on mesenchymal stem cells. So it's interesting to note that we have medications that we're prescribing on a day-to-day basis that, at least with mesenchymal stem cells, seem to have a negative impact on the adult stem cell population.
Okay, and the second part, is there any relationship between the expansion capability and the clinical outcomes?
That's what we're looking at right now. I've got a research assistant who's pulling that data together as we speak, because my guess would be the answer to that is yes, but we're trying to find that out.
Okay, thanks.
Okay, well, let me